Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. All right, everybody, welcome to Own Your Heart Health podcast. I am delighted today to be with a great guest, Dr. Sara Tariq, who actually comes to us from Northern Virginia Family Practice. This is a concierge type of a family practice that Dr. Sara will tell us all about. But the reason that she is here is because we are going to talk about something which had taken me 3+ years to actually realize and to learn, because when I started in the integrative and functional medicine journey, I initially thought that a lot of it was really about giving patients advice on supplements and diet and, and bringing that other alternative care that maybe people were not getting anywhere else. And then one day, a patient actually said something that I thought was very profound. And she said, "You're the first physician who actually spent time listening to me." And I realized in that moment that much more impactful than, my supplement and nutrition and all other interesting advice and my genetic testing was that opportunity that this patient, a lot of other patients have not had before, to be one-on-time with a physician who will actually listen to them. And so, Dr. Sara, welcome. You come from the land where you spent decades, right? Years trying to figure out how to make doctors listen to patients.
Thank you. It's wonderful being here, Regina. So lovely meeting you. I spent about 22 years of my life practicing in academia at a medical school. I spent a lot of time teaching medical students on doctor-patient communication, on how to deal with patients with challenging histories. I was born and raised in the South in the United States, in a state that is pretty, unfortunately, impoverished, where there are not a lot of resources and where there is a lot of trauma. Childhood trauma. And so we have, as an adult, as an internist, I really spent a lot of time experiencing the end result of that childhood trauma, which is patients as adults having difficulty making good decisions about their lives, having a lot of chronic diseases, and feeling like, their doctor does not listen to them, and feeling like they don't know how to they can't sort out everything that they've been through. And what they really need is time and depth. And modern healthcare, unfortunately, does not allow that for a lot of us, right? We have a limited 20 minutes for a return patient and 40 minutes for a new patient, if that. And, we're really challenged by those things.
So I am so glad that you are recovering academician, having been one myself, a recovering academician. And you certainly lended, after you rehab, you're healthy and you've been dismissed,
That's
right? So this is, I think what's happened to a lot of doctors. So tell, I'm always curious, you mentioned some of the childhood experiences. And, where I am from, I wasn't even born in the United States, so I'm an immigrant. And so one of the things that always shocks me, or at least, interests me, is where people are coming from. What are those, childhood formative stories, and how those, we would call them ACE, adverse childhood experiences, are affecting people down the line, health-wise. So how did you come to develop an interest in this area? Were there some, family events or any specific professional interactions that kind of were like that aha moment, like, we should really do a better job speaking to patients, and we're failing patients, not because we're not prescribing, let's say, statins, but because we're just not asking the right questions?
You're absolutely right, Dr. Regina. What really happened over time is, so I'm a general internist. So I've always had an interest in women's health. I've always had an interest in communication and caring for the whole patient. And what I realized working in Arkansas, I was seeing a lot of chronic pain, out of control diabetes, heart failure, poorly controlled obesity, right? And I realized that these patients, a lot of the patients, particularly those who had trauma, and I didn't realize that at the time, would make eye contact. They would answer in very short sentences. They were despondent because their chronic illness was taking over them. And I came across a podcast, and honestly, I was very frustrated. I didn't feel like I was doing a good job for my patients. I wasn't like serving them, and I felt like I was just on the surface. I wasn't going deeper. And I'm not a trained psychiatrist. I don't do mental health, right? But what I realized, I came across this podcast on adverse childhood events and realized and learned that my state, Arkansas, where I was practicing, was either number 1 or number 2 in the country with the highest percentage of adults having experienced at least 2 significant adverse childhood events, meaning a parent who was incarcerated, early divorce, emotional neglect, physical abuse, poverty, right? Having proximity to drugs, right? So these were the patients that I was taking care of. And when I dug deeper, and there was a large, very significant study out of California from Kaiser Permanente that looked at about 16 or 17,000 adults and went backwards and assessed their adverse childhood events and looked at the risks of lung cancer, heart disease, and independent of smoking, by the way, diabetes, obesity. And what we know is that this chronic stress and the chronic high cortisol associated with chronic stress has these long-term effects down the road, not only cardiovascular and vascular, right? Vascular effects on your blood vessels and your blood pressure, but also on how the brain develops and how people process illness and how people feel like they can overcome their illnesses, right? And make the right decisions when the decisions are complex.
Right. And I have to tell you, it resonates with me deeply because a few years ago, I was sort of straddling two worlds, right? So I had my private practice, which is North Shore of Long Island, which is a fairly wealthy, well-to-do area here. It's a suburb of New York City. And at the same time, I was chief of cardiology in a community hospital. And this community hospital, it was a contract with our regional healthcare system, which was, based in a wealthy zip code, but the community hospital itself was unfortunately in the area which was impoverished. It's a beautiful area in terms of surroundings, but it was an inner city area serving the second largest Medicaid population in the New York State. And so it was perhaps maybe like a 40-minute drive for me between two of those locations. But every time I would go there, I felt that I was transported onto a different planet. And the reason being is that I have never seen these type of interactions. They were not, something that I was used to, because I would give a patient an explanation about their condition and about the next step. And I could see that they were not listening and they were not processing it. And it wasn't because I was explaining things in too difficult terms. I always make sure that all the cardiology terms, I simplify it, I draw pictures. I realized very quickly that these patients, they didn't have hope. They didn't think that they could improve. And so the first intervention was actually to give them a sense of that mastery, that hope that they didn't have, because their entire environment was so adverse and so terrible to them. They had those adverse childhood experiences, and those unfortunately continued into adulthood, that they sort of resigned themselves to things just being bad. I mean, is that what you had seen? That's what you were referring to?
100%. 100% patients who, like you said, their eyes cloud over because they just can't see the options. That awareness, or the doors in the brain that open when you say, let me think about the options here for treatments and how I can get better. It's almost like those doors in their mind never open. right?
Right.
Very much similar to what you're talking about. And it leads us as physicians to feel frustrated, and there's an urge to dismiss them, right? Oh, they're not interested in, they're not compliant. And in actuality, when we dig deeper, we see that there's a much larger problem. And we don't want to be in the pattern of the victimization, right? We just ignore them and we develop a bias against them. And in actuality, these are the patients who need the most help in this country.
And this is so true because, my initial I thought, well, maybe they just don't like me, right? I don't look like them, I don't sound like them. Yeah, I have an accent, they do too, but it's a different accent, it's New York. Like maybe they just don't like me. But then I came to understand that it wasn't really personal. It was sort of like the defense shield that they had to build over many, many years. And for them to trust someone and to allow these emotions and fears and concerns to come to the surface, that was a huge, huge step for a lot of these patients. And, and I never forget, there was one patient in particular, and you know how these arrangements are, right? The community hospitals, they have certain set of services, but then of course the parent healthcare system has all the tertiary services. And this happened to be a patient, a fairly young patient with end-stage heart failure. And, I know you and I have both seen it. And this patient needed a device. He needed a device therapy. And this was yet another one of those, emergency room visits where he was in acute heart failure. And I said, okay, we need to transfer you to the mothership because we really cannot put these devices here. And I went to call, the appropriate channels, and they said, oh, we know him. He's non-compliant. He doesn't come. He's this, he is that. He used to be a drug user. We're not even sure if he's using now or not, but we're not going to take him. And so didn't know this patient. I came back to the bedside and I said, this is what I'm told, what's been your history with that? And he looked me straight in the eye and he said, Doc, he said, you have to fight for me because I am fighting for myself. And so we did transfer him and he did get that device therapy. But the amount of work that it took to get that done, the sort of institutional and personal bias against a patient like him coming from this very impoverished, difficult, dehumanizing environment was extraordinary. And it got me thinking, maybe I'm part of that problem too. And I don't even know about it, right? I'm judging these patients.
Yeah, it absolutely goes back to our unconscious bias, right? All of us harbor some sort of bias that we're not even conscious of. And we have data showing that certain people from certain races and certain socioeconomic classes, they don't get heart caths as opposed to other folks, right? Mm-hmm. Their chest pain gets dismissed as panic or anxiety. In women, we see that all the time, right?
All the time.
So you're absolutely right. So there are these biases and the system works against these people, right? And the cycle of poverty and the cycle of lack and the cycle of, not having options, it's sort of become comfortable with it. And it's a blessing that your patient was able to see you you displayed the compassion that allowed him to say, Doc, you got to fight for me. Because that's not usual. A lot of times they don't say that because they don't trust their physicians for good reason, right? And so it takes advocacy, and advocacy takes time away from other things that you could be doing. But that also takes heart, right? It takes the heart on the part of the physician.
Exactly. There is no RVU for advocacy. I can tell you that much. So tell us, what is your sort of approach to this, right? Do we have a system, for example, that would allow us to identify or somehow, I know there is adverse childhood experiences questionnaire, right? One can do that with patients. But, what is the approach? What is the system? And how we as practitioners can become aware of some of these implicit biases that we have, and we're bringing it into our patient interaction. And, what's the opportunity for us to step back and say, hey, I need to do things differently?
I think you asked two really important, really big questions. One is, how do we address unconscious bias, and how do we do it systematically within the healthcare system? And number two, how do we address trauma, right? So let's talk about unconscious bias. One thing that I've really enjoyed doing is I've been trained as a facilitator for unconscious bias, where we go to companies, organizations, hospitals, faculty groups, and we teach interactive workshops about unconscious bias. And once you do that, and that includes having physicians and healthcare providers take the unconscious bias test, which is the Harvard Implicit Association test, the Harvard AIT. It's free.
All right.
You Google it. It's free. It's easy to take. But debriefing yourself on it is hard because, and you can take a bias test on obesity, and we know that we physicians have, as a profession, have a bias against obese patients, our obese patients. We can take a implicit association test about women and men, race, religion, LGBTQ. And so the first step in addressing our bias is to first know that we have it, right? And oftentimes we don't until we take that test. And that test has been validated and has been studied and documented in over 300 or 400 different articles and journals and scholarly work. So it's a very widely used, easy to take quiz. So that's the first step. But it is scary to realize that you have a bias. And so it's very jarring, right? So you've got to be sort of prepared for that. And so we do some training around that. And I've gone around the country doing that. The second thing, when it comes, and that's a huge conversation about bias, but we've got to address it. And I'm so grateful that many, at least academic centers, are doing so. The second thing about trauma, the scary part of trauma is I'm an internist, right? I don't do mental health. I'm not going to dig into that. I don't have the time, honestly, to dig into trauma. So here's the one question I ask. And I don't dig deeper after this, which is what I say. A lot of people have gone through significant trauma in childhood, which we call adverse childhood events, like this list, right? And I ask, have you ever experienced that? And I ask it in that soft, slow voice. I give space because it's a traumatic question and it has a potential, right? To trigger somebody. And I ask the question and I just wait. And usually when I suspect it, the answer is yes. And I say, I don't ask what it is. I just say, you're not alone. In Arkansas, for example, it's really common. And we have lots of resources that we can help you address that if you feel like it's getting in your way. You don't have to do it today. You don't have to answer. Just know that we're here to help. And I leave it there. And almost 80 to 90% of the time, I see relief on my patients' faces when I ask that because they feel seen, right? I'm not going into the details. I'm not here to gossip or learn just what happened. I just want to know. I just see that they're experiencing pain in the clinic visit, and I want to acknowledge the source of that pain. And so there are trauma therapists, at least that we had at the medical center, and that there are many trauma therapists up here in the DC area, and I'm sure in the New York area as well. And it's a growing, there's a lot of growing information and therapy focused on this trauma.
Yeah, absolutely. And I think, in the integrative functional medicine community, this is also a rapidly growing space because there are a lot of interesting programs that teach patients how to reprocess trauma, right? How to sort of reframe those experiences. And, I had seen some great results. Again, I'm a cardiologist, so I don't know how to do it, but I can ask and I can refer. And I had seen some patients actually benefit from it, quite significantly. So the question then I have is that, do you feel that some form of this assessment should be part of every new patient encounter, right? Because patients could mask pretty well, right? They could come appear to be super well composed, and you don't even understand internally what their fear is, like especially like in my area, cardiology. I know, like from just my patient experiences, that most patients in the back of their mind is not how much do I lower my cholesterol. It's about, am I going to die of a heart attack or not, right? So that's sort of like the connection in the back of their brain. So how do we even start this conversation? If like, do we assess everybody just sort of like across the board? Like, is there any maybe online tools or things that potentially we could use to give us a clue?
That's a really good question. And I thought about that. And I honestly haven't figured out the best way to do this. Sometimes it's just so I haven't operationalized this on all my new patients. And I'll be honest and transparent. Some of it's because of a little bit of hesitation, because I haven't gotten to know the patient well yet. And so I want to make sure that I build trust and that they feel comfortable with me. And then by the next visit, I'm dealing with other issues. But when I sense a roadblock, when I sense hesitation, when I sense noncompliance or non-adherence, that's when I ask it. But Dr. Regina, you bring up a good point. Maybe we should explore that, right? Because I always ask about mental health history, right? I ask past medical history, past social history, surgeries, mental health history. And so that's really a door. Once you ask about mental health, then that may open the door to asking that one question about trauma, again, without digging deep and without asking further questions. But I think you bring up a really valid point. People mask this all the time.
They mask all the time. And, in functional medicine, we have something called a functional medicine matrix, right? It's sort of this framework that we use that runs a specific hierarchy of how we interpret things that people tell us. And then, we have so-called nodes, right? So we try to, like, we can think of as connecting the dots. But the reason that I'm bringing it up, and, people can find it online, they can just put, functional medicine matrix and they'll see it. At the center of that matrix is a very special place, and it's called mental, emotional, spiritual, right? And initially, when I started in this journey, being a cardiologist and a scientist, we like things which are exact, right? We can measure our ECG intervals in milliseconds, damn it. Like, this is how exact it actually gets, right? And I said, mental, emotional, spiritual. It's nice to have it there. It's like a soft spot, right? But that soft spot was right at the center, at the heart of the matrix, pun intended. And the more I started to progress in my work with patients and sort of understanding myself, the more I realized if I don't address this center, this mental, emotional, spiritual, we are not going to make progress. We can make some progress, but there is not going to be a transformation, because that's where the real leverage lies, in this mental, emotional, spiritual space. And then, of course, there's a lot of great work from Dr. Peter Libby's group on the connection between stress and activation of mental stress through pain and how it mobilizes our immune system. And their work is very elegant. They showed that this mental stress, for example, pain, stress from other reason, through mobilization of immune response, creates an echo in the blood vessels that actually grows atherosclerotic plaque. So there's an echo phenomena of this mental, emotional, spiritual influence. It imprints on our blood vessels every single day.
Wow. It makes sense, right? It absolutely makes sense, because more and more literature is coming out. I think there was a study that came out of Wisconsin and maybe 5 years ago, pre-pandemic, that looked specifically at the effect of stress on the blood vessels. So there is hard data on this. And of course, in primary care, we learn the biopsychosocial model, right? And I think we forget about that when we practice medicine. They're all intricate. The social environment in which our patients grew up, how they live, where they live, their zip code, all of that influences their health, their psychological status, all of that influences their health. So we really can't we can't properly assess and treat the body, the bio, without including the psycho and the social in the equation. And I think that's probably why I did primary care.
I know. So let me ask you this a more difficult question. So you have transitioned from an academia into a concierge primary care, right? And so how does concierge or direct pay primary care solve or improve upon this problem that we're discussing?
Absolutely. So the benefit of the reason why I left 22 years of academia and joined a concierge practice, honestly, I'll be very honest, the main reason to move to the DC area was for family. I may not have ever have left academia if I didn't leave Arkansas, because I really enjoyed my job of taking care of students and focusing on wellness and all of those things, and taking care of patients and publishing. But what was missing was that I never had the time that I wanted to spend with my patients, and I could never dig deep like I wanted to in a 20-minute visit, right?
Yeah.
And then my patients, as you know, if I say, I want to see you back in a couple of weeks because I'm not done with you, my nurse would say, Dr. Tariq, you don't have any openings for 3 months. What concierge does is, because it's a membership that our patients pay to be in our membership, I have time. I have the time to dig deep. If I want to see a patient every 2 weeks because they have an acute issue and they're dealing with a crisis in their life, I can do that. If I'm dealing with a really complicated subject, I can see a patient for 90 minutes. I can say, I want to see this patient back in 2 weeks for 90 minutes. So it gives me the flexibility. And I'll be honest, Dr. Regina, I was worried that I didn't enjoy patient care anymore with the urgent, 11 patients in a half day.
Well, you didn't have the pressure.
Yes. And I was sad that I'm like, do I not enjoy primary care anymore? And then when I joined a concierge practice, where my CEO said, I'm primarily at the center of all of this, not just the patient's health, but the doctor's health. And I thought, oh my gosh, this is amazing. And so I have the luxury to see my patients as often as they need until their medical issues are sorted out. I can dig deep. I can look at the literature. I can study. I have time. I'm not pressure. There's no pressure. And that's the gift of concierge medicine. And partly I'm sad that has to happen, because healthcare is really broken right now. But I'm glad that I'm able to serve the patients with 150% of my heart and soul, that I can do that, and that's really why I joined.
And, this is really true, because, going back to my experience, sort of straddling those two worlds, right? The inner city population with lots of complexity and lots of disadvantages. And then, coming back to my private practice, where patients were so much more attuned to what needs to be done, and they did their research, and they wanted to do all sorts of various different questions. And so, these were so different. And then one of the things that came out from it, which was sort of unexpected, is that I learned that for patients in those adversely affected environments, you actually don't need much to move the needle in the right place. They didn't need some crazy interventions. They needed simple things and people who provided consistency and who they could trust. And then the opportunity opened. And when the opportunity opened, the changes were absolutely amazing. And so, and I feel like, yes, I'm sure that there will be some critique, and some people say concierge medicine is not accessible to everyone, right? It's a legitimate critique. Integrative medicine is not accessible to everyone. Yeah. But I think we also have to be cognizant of the fact that there are so many models right now, direct payment models, that, yes, patients could come and experience this style of practice at a very reasonable budget without, and actually make real improvements, as opposed to being stuck in the sick care system, day after day and year after year.
Absolutely. Absolutely. So
Very interesting.
And so for us, it's a membership. We do take your insurance. So it's not like you're entering a practice saying, I might be $20,000 in the hole after the year, depending on how sick I get. Mm-hmm. No, it's a membership. And then everything else is insurance based. So if you need something serious happens, you've got the insurance and you don't have to pay that out of pocket. And so that, I think, helps, because it reduces the uncertainty. associated with, oh my gosh, how much am I going to have to pay every time I go, right? And so that's a nice thing about this practice.
Interesting. So it's more of a hybrid model, right?
Yes.
It allows people to kind of, have a way, like it's almost like, I'm not going to say a safety net, but a plan B.
Yeah, absolutely.
Interesting. So what do you think? This came to my attention recently, but it's obviously came to everyone's attention. So I think this is something that a lot of docs are experiencing. We have this field in our intake form every time a prospective patient reaches out to us for integrative cardiac care. There is one question there that says, "What is your top health concern, and how we may help?" And so recently, I saw a patient who literally copied and pasted a very lengthy response, most likely from ChatGPT, could be some other generative AI model, that have gone into tremendous depths of the lipid analyses. And that was this patient's response to this question: what is your top health concern? When I know in the back of my mind that their top health concern is that how I not drop dead from a heart attack, but that was the generative AI output. So do you think that these generative AI tools, because, they're accessible, they sound nice, right? They sort of give you lengthy explanations. We had a study in JAMA where, people preferred generative AI output to physician communications through the portal. Where does that position us in that doctor-patient relationship? Like, what, do we lead into this, or do we lean out? Like, kind of, where should we be?
Yeah, that's a really good question. And I think it's a question that so many of us are grappling with right now, right? I feel like the human communication cannot be replaced. There was a study that came out that is even looking at AI as therapists, replacing therapists, which just boggles my mind. So I think AI, just like any other tool, if it's used properly, can be really helpful in advancing and making medicine easy for us, right? So I see a lot of complicated patients. And usually that's when people come to Concierge, or at least so far in my experience, they've come because they're like, I've seen 4 other doctors. They spent 10 minutes with me and they said they have no idea what's going on with me. I know something is going on with me. Do you have the time to do this? And my answer is always yes. When we ask complex questions, complex answers take time. AI helps reduce that time to nothing, right? I can ask, what is the evidence-based guidelines for the detection of so-and-so? Or, how often do we see neuropathic ear pain post-operatively from a tonsillectomy, right? Those are the kinds of questions that I feel as physicians using AI is a huge tool. For patients, I feel like that I want to see a lot more evidence in terms of AI taking our spot. I just feel like at the end of the day, humans, particularly with complicated issues, right? With complicated multi-system issues that we manage as internists and cardiologists all the time, are going to need another human to put the pieces together. So I'm not scared yet. I'm a little cautious, but I'm not worried yet. I might be naive though.
No, I'm with you on that. And I listened recently, I think Dr. Jeffrey Hinton, who is considered godfather of AI, he was interviewed on the news, actually on CNN. It was a couple of days ago. And he made an assertion that we must make AI have maternal instincts, because if it doesn't, in his words, not mine, we all will be toast. So that's how he positioned it. And I said to myself, I think he is onto something, because at the core of medicine, at the soul of medicine, is taking care of people. And so it's not taking care of information. It's not giving you better and better information. It's taking care of people. And this is exactly what he is saying, because, regardless of how great the output is and the laboratory analysis or anything else, it is still not taking care of a person, because a person is so human, so multidimensional. But I think there is an opportunity. For example, could AI? Do you feel could AI widget of some sorts screen patients for those adverse
Yeah.
childhood
Yeah.
experiences?
Yeah.
Right, and give us some sort of a heads up, and give a patient some heads up before they go into the
That's right.
encounter that this might be what's going on.
That's right. As a tool, I think it does have a role. Absolutely. But I think you and he hit the mark. Like, it's got to have maternal instinct. It's got to have that human and the deep empathic instinct where there's a ping in your brain where you go, you know what you just shared with me for the past 20 minutes, there's something not right about that. I don't know what it is yet, but I'm going to find out because I deeply care. So I think
Right.
you're absolutely right. So I feel not threatened at this point.
At least not yet, right?
At least
So,
not yet.
so what is your advice? Because I've been grappling with this issue, as obviously seeing patients. I recognize sometimes that I may have a bias, but my patient may have a bias too, right? And certain, like, especially in this area like integrative functional concierge medicine, there are some very interesting biases that sort of pop up, right? And then they're all over the place. How do you advise, to structure the encounter, or do you have a system that sort of allows you to spot check and say, I think this patient is showing, let's say, availability bias, or some other bias, right, or recency bias, right? Like especially recency bias is classic, right? It's a situation where we've done a lot of work with the patient, we dug into the lifestyle, they've done a lot of changes, and then they saw on the internet that a certain supplement is a magic bullet. They took it for 3 days and now they're remarkably better, right? So the whole, like this recency bias comes in. So what's your system? Do you have a system?
The one thing that I do, and I feel like, again, it's this is going to sound a little touchy-feely, but really the human interaction and the trust that develops between the physician and the patient is really where I start from, right? And so I always start with when I see my first visit, I always talk about my philosophy towards medicine, which is trust, number one, and shared decision making. That my trust is not, I don't get to, I have to earn my trust. I don't think I deserve trust because I wear a white coat or I went to medical school. That's earned. And my trust is earned from my authenticity, my honesty, and my sincerity. The second thing is shared decision making. I always say, I want you to bring new ideas that you may have read about or heard about to the table. I'm going to bring my 22 years of experience and med school education to the table too. Let's talk about it. I could tell you to take a statin all day long, but if you don't believe it, if you don't trust it, if you've heard of your aunt having a problem with it, you're probably not going to take it when you go home. And so I want to let's put it out on the table. It's in a neutral space. It's a table. Let's talk about it. And we're going to come to an agreement. And we might not come to agreement today, but let's continue to talk about it. And so those kinds of authentic, transparent conversations where I acknowledge the inherent power that the patient brings to the table, I think can mitigate some of those things, or at least create space for the discussion.
Right. I agree with you. I mean, and I love this table analogy, because what I tell patients is that it is a partnership, right?
Yes.
It is a patient-physician partnership.
Yes.
And partners have responsibilities and partners have accountabilities. And this is what we have to respect and go by if this relationship is to be successful, because there is not going to be a magic bullet, right? We're physicians, we know this. There isn't a magic bullet. Magic is inside each individual patient. We need to help them unlock that magic, so to speak, that opportunity for transformation. But it is only possible if it's a true partnership. And partnership is hard, because you have to be honest, you have to communicate, you have to call things out when they're not right. Partnership is really hard. It's a big sort of redefinition, I think, for those of us who are practicing in a different space. And we have that, in many ways, a luxury of practicing in a different space.
Absolutely.
It is a redefinition of what a medical encounter or doctor-patient relationship actually is, unfortunately, in a lot of other instances.
Yeah, absolutely.
Yeah. All right, Dr. Sara, any parting words for our listeners? What do you want them to do if they're asking themselves, do I have a bias? What are all these interesting biases that they're mentioning? Should I go score myself on some sort of a bias scale? Like where they can find the resources, where they can find more information? Give us some
Absolutely.
wisdom here.
Absolutely. I think I definitely am a big fan of the implicit association test. I've used it on my medical students. I've used it in lay people. It's easy to take. They have lots of teaching materials around it. And I think the other thing that I'm going to really push, less for the patients and more for us physicians, is I would encourage all of us to engage in bias testing, to look at our biases, because once we are aware of our own biases, then we can talk more about it and the ideas spread, right? For me, I don't want to put any onus on the patient. I want to put the onus on the physician. And I know that seems harsh in some ways and strict, but I feel like we're in a position of power and privilege. And I want to push the CEOs of hospitals and the CEOs of companies, anybody in the service industry and healthcare, especially because lives are on the line. I definitely would want to push bias training and discussing and DEI training. Now more than ever in this divided, scary world where we use social media and we end up feeling a little isolated. I think more than ever, the human connection is where we have to go towards.
You got it. And great words. And we're going to include a link to this test. I'm actually going to take it myself and see how I get scored, so hopefully not too bad, but implicit bias test, going to test and end up with the results, put links in our show notes. And I encourage all of you who are listening to this, do take this test so that you can learn a little bit more about yourself and hopefully make your doctor-patient relationship more satisfying. Thank you so much, Dr. Sara.
Thank you so much, Dr. Regina. It's lovely talking to you.
You too. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.